Good morning, everyone. I'll be presenting you today the Rwanda's National HIV Program response when it comes to maternal and pediatric HIV. Starting with epidemiology, for most of you who don't know where we are currently as a country, you'll see that in general the HIV prevalence in Rwanda has been stabilized since 2010 to 2020. We have a prevalence of 2.7 among 15 to 49 age group. And over time, the prevalence stabilized for a decrease in all age group, except for the 45 to 49 years old, as many countries are showing that we have aging population on ART. When you look at the geographical distribution of HIV prevalence over time, we have an HIV prevalence that has considerably decreased in the city of Kigali, where we had initially a high prevalence in the last 10 years, and with an increase in some districts in the eastern and western provinces. So these particular provinces, we have a high number of AGYW, and also some of those districts in those provinces, they're bordering to other neighboring countries. So as many countries, as you know, with those geographical status, we have some kind of like a high increase in HIV infections. So when you go to the program implementation strategies for maternal and pediatric HIV, starting with the elimination of mother-to-child transmission, generally we have a coverage of PMTCT at 99%. And we have a mother-to-child transmission, which is below 2%. So this is what the slide is talking about, where we have over 99% of pregnant women living with HIV receiving ART, which has decreased significantly the mother-to-child transmission. But as you know, some countries, just like our country, we have a slight difference with the UNAIDS report, where it shows that we have a 5.78 transmission rate, with 0.48 and 1.5, which are infected by mothers who circumvent during pregnancy. So these are the major gaps we have in the program of PMTCT, where we came up with ongoing studies that currently following up pregnant mothers and their children, not only during PMTCT, but also right after, where we have to follow up during the vaccinations, and we do offer them a chance to have their children tested for HIV. So we are still in the early phases of these studies, and we hope to share with the rest of you or the world with what we come up with the result in these studies. So for pediatric HIV, starting with the general population, the coverage, we have had an increase in the coverage from 87% to 96%, where we have reached the UNAIDS target of surpassing 95%. But when we go deeper closely to the pediatric population, we have where we still lag behind, but also a slight increase in the coverage, where we have gone from 60% in July 2021 to 76% by June 2024. This is quite an interesting increase, and we have had some strategies to deal with it, but also we've also had some kind of like estimates, UNAIDS estimates, saying that we have particularly like a large number of children who don't know their status, which also comes right to the coverage that keeps going down. When it comes to viral load suppression among pure HIV, we see a steady increase, and also a general reaching the target of 95 among general population, but we still kind of see a lag behind among children below 15 years old. As you can see, when you talk to undetectable viral loads, for children who are less than 15 years old, we're still around 80% and 71% for female and male. And when it comes to those who are unsuppressed, we still have a bigger number when compared to the general population. Generally, as other countries, we still have poor outcomes when it comes to the pediatric and adolescent population, but we've come up with strategies to be able to respond to the pediatric gaps that we have, such as the Lift Up initiatives, which was a surge case findings of children, because we thought that if we know the right and the current number of children who don't know their status, we should be able to increase the coverage of ART. So this initiative initially started in 9 districts out of 30 districts, and we've had, we were able to test 21,000 children, and we've come up with 57 positive children who initially didn't know their status and were not on ART, and currently they are started enrolled on ART, and we believe that enrolling or scaling up this initiative to the rest of districts, we should be able to see those other children who were like probably running around with HIV but who are not on ART. We've also thought of doing an adolescent model, which is basically involving adolescents and their carer, but also their peers and their school teachers to be able to get involved in the response of HIV, to be able to come up with a better outcome when it comes to ART adherence, but also viral load suppression. We also want to focus on the quality of data, because if we are able to, as a program, to record 99% of pregnant women who are receiving ART and less than 2% of children who get to be transmitted HIV, but also we have UNAIDS having different kind of numbers. We want to be able to see, is it the program that have some kind of data quality, but also we know that the estimates, when you give in garbage comes out. So we want to be able to have better data quality, but also to promote research and innovation to advance HIV response. We also are working into integration models, not only for adults, but also for children and adolescents, where we have HIV services with sexual and reproductive health and mental health services. In general, that's it for our response as a country for the maternal and pediatric HIV. Thank you very much.